talk a little bit today about psychotherapy for acute care settings. And I have one additional disclosure in that the School of Medicine directs us to indicate that we used AI. So I did use AI, and you will see the ways in which I used AI as the presentation goes along. So I'm really excited to be here today to talk about my favorite topic in psychiatry, which is psychotherapy. I feel really grateful to the department and its wholehearted support of psychotherapy. I really feel that we as a department believe in the mission of providing psychotherapy to our patients. And I'm very grateful to have been trained and now teach at Hopkins, where I've had a lot of wonderful examples from important mentors of how to do psychotherapy on the inpatient unit. So today we're going to describe the common factors of psychotherapy, review the WHY model, which is the basis for the psychotherapy curriculum in the training and teaching of residents, briefly describe the evidence base and effectiveness for psychotherapy, describe how core psychotherapeutic approaches can be used in acute care settings, learn how several approaches are being implemented in the curriculum in the Jerome Frank program, and to review challenges and opportunities for AI use in psychotherapy for patients experiencing severe mental illness. So in my 4 years in my role as chair of the psychotherapy committee at ADPERT, I've gotten to know the landscape of psychotherapy nationally. And I know by this from talking to lots of my colleagues that we have a very strong program here at Hopkins. I think this is for two reasons. One is that we use a perspectives-based formulation in considering patient illness, which really allows us to examine all of the aspects of a person, including what elements of psychotherapy might be the most helpful. And the legacy of our program is based on the work of Dr. Jerome Frank and his groundbreaking work on psychotherapy, including the factors that make up its common elements. And Dr. Frank gave this really important quote, given the fact that most of the people that are presenting for treatment come in for treatment of demoralization. And his view that patients can be demoralized due to illness versus other life circumstances is defining. And he said the chief problem of all patients who come to psychotherapy is demoralization. And the effectiveness of all psychotherapeutic schools lies in their ability to restore patients' morale. And I think we all need to keep this in mind as we're trying to help our patients, particularly in acute care. So what are the common elements that he identified in terms of the frame of therapy or how we provide treatment? The first is a healing agent, and that's all of you in the audience. It's a sufferer seeking relief, which is basically our patient who is in distress at the time that they seek care with us. And a healing relationship, which is a contract between a healer and a sufferer, in which the healer tries to bring about relief of symptoms. And this relief of symptoms is accompanied by changes in inner emotional state, attitudes, and behavior. And the common elements of psychotherapy are very important because although physical and chemical adjuncts may be used, the healing influence in psychotherapy is exercised primarily by words, acts, and rituals in which the sufferer, healer, and sometimes a group participate jointly. And basically this is indicating that you have to have a treatment plan with your patient for the type of psychotherapy that you're going to be doing and the results that you expect to see. People who are engaging in psychotherapy need to understand how this will help them and how it will help them to have a better day, as our patient mentioned. And I really think of psychotherapy as the most common procedure that we do in psychiatry. We are doing an intervention. And so one of our speakers that I was fortunate enough to hear here at Hopkins was Bruce Wampold, who wrote an entire book on the effectiveness of psychotherapy. It's a really great book, and I'm not going to cover all the ways in which psychotherapy is effective, but if this is something that's of interest to you, I highly recommend that you read his book for the evidence. And he was also a contributor to the most updated version of Persuasion and Healing, so there's also a brand new version of Persuasion and Healing that I recommend for everyone as well. So how is psychotherapy effective? And one of the things that I really loved about Hopkins when I came here as a trainee was that people said, we don't know. We don't know how the brain produces the mind or produces consciousness. And it's something we're working on as a field, and we would love to know the answer, and we have many smart scientists working on these questions, but we don't know. But in theory, we believe that psychotherapy changes neural networks in the brain to produce associated changes in emotions, thoughts, and behaviors. So the current state of the field is this debate between clinicians about whether common elements of all theoretical orientations produce change, or if certain orientations are preferable. And when you talk to real experts in the field, they really talk about how this has been kind of at cross purposes to our true intention, which is to get more psychiatrists to engage in psychotherapy. Because the common goal of all psychotherapies is to produce change, a change in the sense of the person's internal suffering. So currently it's believed that no one therapeutic modality is better than another, but the best practices are to get a broad exposure and then gain expertise after this broad exposure. And I would argue that the first step for severely ill patients is restoration of hope through a combination of pharmacotherapy and psychotherapy. And how did Dr. Frank suggest that we do this? So through what he called the rituals and procedures of therapy, which include establishing a therapeutic alliance. A lot of the data suggests that this could be the most important factor in terms of the effectiveness in psychotherapy. Instilling hope in the therapeutic process in patients that might present with hopelessness as a chief symptom that will allow them to have new learning experiences in the safety of the therapeutic setting, or the holding environment as it's sometimes referred to. Helping patients identify, feel, and reprocess emotions from present relationships and past ones as needed, which facilitates a sense of self-efficacy as they make a positive change. This offers opportunities for the patient to practice new behaviors as they learn about themselves. So this is a really interesting study that came out this year about hope in the life course of patients. It was a longitudinal study that started in 2007 and lasted all the way till 2021. And it had 25,000 subjects. And it was really interesting in the fact that high levels of hope showed improvements in educational, economic, and employment outcomes, as well as well-being and perceived and objective health measures. Now, they mentioned in the study that psychiatrists often refer to this, but there's not great evidence yet. But it was really great to see this study that actually backed up all the important things that were been taught, like the importance of having people, when they come to the inpatient unit, understand that we've seen this many times, we have hope, we know that you're going to feel better, is one of the most important messages that we give on our inpatient units. And the most interesting thing about this is that patients with high levels of hope were less likely to be influenced by negative life events and adapted better after these events. So there is evidence to say that if you can instill hope in people, they then become more resilient and are able to weather difficult life circumstances better. And conversely, the loss of hope can be a significant warning sign that something's going wrong. So how do we teach and learn psychotherapy then, if it's such an important modality for all of us to practice as psychiatrists? And while writing a lecture for the third-year clerkship students, I found a film of Dr. Frank talking about methods of psychotherapy. While he believed in common factors, he also recommended being taught a variety of methods so that we can be sure about our approach. The idea was not to rely on these methods to make interpretations that could seem at odds with the patient's presenting concerns, but rather to understand a roadmap for how treatment will occur and how to convey the plan to the patient as to how treatment will succeed. He also emphasized that a chosen modality should fit comfortably with the temperament of the therapist, which he described as my most favorite quote in all of psychiatry, a method that's congenial to you. I say this all the time. Understanding a method also assists a therapist in knowing if the patient's responding to therapy. No matter what type of psychotherapy is being learned, all should include training in alliance, the therapeutic frame, and managing boundaries, because these are elements that are common to all modalities. It's also important to discuss how to repair therapeutic ruptures. As therapists, we're not always going to get it right. We're not always going to understand the patient on the first try. So we need to be able to incorporate feedback from patients and from supervisors at all levels of our career. So a way to help trainees see how these seemingly disparate models of psychotherapy can be connected is through the why model, which helps residents understand commonalities in the modalities of therapy. This model incorporates elements from the 3 required forms of psychotherapy so that the residents can see how they're integrated. The core of the why model is formed by supportive psychotherapy and other modalities that are based on therapeutic alliance. And the branches, the 2 branches, contain psychodynamic psychotherapy and cognitive behavioral therapy so that the relationship among the 3 can be understood through core processes. Now, I've heard other people refer to the shaving brush model, which basically means that all of the different branches, both the different branches have lots of other modalities of psychotherapy coming off of each stem. But, basically what we want to do is that, we want to understand that there's many, many methods that you could use to get your patient feeling better. And as described by one of our prior invited lecturers, Dr. John Markowitz, the branches can also be considered to be the exposure-based therapies on one side, which we heard about from our patient today, as well as the affectively based therapies on the other, such as psychodynamic psychotherapy or the modality we teach in our family therapy clinic, which is emotionally focused psychotherapy. Contrasting the goals of psychotherapy, supportive psychotherapy with psychodynamics, this is like an example of how you use the Y model to teach. And how we talk about sometimes in our psychodynamic seminar, where we talk about what would be a CBT-related interpretation of what's happening with this patient versus what would be a psychodynamic interpretation of what's happening to this patient. Supportive psychotherapy focuses on hearing and understanding emotional experiences and affect regulation, while psychodynamics focuses on affect and the expression of emotions. Supportive psychotherapy organizes patients' experiences into a cohesive narrative, while psychodynamics identifies patterns in patients' thoughts, feelings, experiences, behaviors, and relationships. Supportive psychotherapy promotes focusing and adapting to the here and now, while psychodynamics emphasizes the patient's past experiences and how they may influence the present. Supportive psychotherapy works to enhance social support, while psychodynamics emphasizes the role of the therapeutic relationship and interpretation of that in producing change. Supportive psychotherapy increases impulse control, while psychodynamic explores resistance toward painful affect that hinders therapy. And an understanding of all modalities helps the residents expand their therapeutic repertoire and find that modality that's most congenial to them. So now I want to talk about something that's, I think, specific to Hopkins. As somebody that's practiced psychotherapy and psychiatry at Hopkins since I was a resident, I was perplexed when I heard that most other training programs divide outpatient care into medication pharmacology clinics and psychotherapy clinics. I didn't understand how talking about medications was not part of psychotherapy, because an important consideration for psychiatrists is how patients feel about their medications and how temperament and symptoms of illness all play a part in this. It's particularly important for the complex patients that we see at Hopkins, as these patients almost always require an understanding of both psychopharmacology and psychotherapy. And understanding the role of psychotherapy in medication management is an opportunity for teaching in terms of making meaning of patients' experiences. To summarize, providing the best care requires a foundation in psychotherapy, and an exclusive focus on psychopharmacology without discussing how patients are feeling about taking these medications will feel less effective. Multiple psychological factors, including neuroticism, defensive style, locus of control, attachment, and readiness to change, all affect treatment outcomes. The complex patients we typically care for in our units benefit from understanding of these factors. So, empathic support of a patient struggling with symptoms of illness builds treatment alliance, which can help with ambivalence toward medications, particularly as many of our medications have difficult side effects or take time to become effective. A strong treatment alliance predicts more acceptance of medications, particularly when side effects, stigmatization, or the symptoms of illness itself create difficulty with medication adherence. At times like this, what's termed an increase in the dose of the doctor can be extremely helpful. That's why it's super helpful when all of our residents do things like Dr. Bigley did and like many of our PGY2 residents do, where they go back in the afternoon to help discuss with the patients what happened on rounds, how they're feeling about their illness, how they're feeling about their prognosis. Additional therapy sessions, particularly those on the unit, can help prevent discontinuation as medications are titrated to an effective dose, and asking about ambivalence in an empathic, curious, and sensitive manner can help patients reveal concerns they have about taking medications that might initially be withheld, such as sexual side effects or concerns about the implications or prognosis of their diagnoses and experience of illness. It helps to have training in how to adjust therapy modalities into brief formats that can be applicable to many therapeutic settings. And this is a really great series from earlier this year that covers brief formats of supportive, cognitive behavioral, and psychodynamic therapies. and provides guidance for short-form combined therapy. It's really aimed at how to meet different outpatient billing requirements, which is a standard barrier to practicing psychotherapy as a psychiatrist. But I really think it's fantastic for learning how to do briefer forms of interventions on the inpatient unit as well, and I share it with my psychotherapy supervisees as a guide. So psychotherapy training and supervision might be the most important thing about learning psychotherapy in our field. It's essential for learning how to maintain boundaries and the therapeutic frame, as well as how to understand what feelings belong to the patient and what feelings belong to the therapist. While it's essential to learn psychotherapy through meeting regularly with a supervisor during training, and thanks to all of you out here who are psychotherapy supervisors, much appreciated, seeking supervision is a lifelong professional skill of a practicing psychiatrist and centers us in the treatment of patients and in our own ethics and conduct. So why is psychotherapy so important for acute care settings? And this is really because the best outcomes for most psychiatric conditions are seen with the combination of medications and psychotherapy. And the APA position statement indicates ideally this should be done by the same person when possible. So this is a systematic overview of meta-analyses that indicates that combined pharmacotherapy and psychotherapy is preferable in virtually all diagnoses in psychiatry. It looked at both pharmacotherapy added to psychotherapy and psychotherapy added to pharmacotherapy and overwhelmingly favored combined therapy. Of course, there were different effects for some different types of therapies as well as some diagnoses. But knowing this, there are many possible choices that could be effective for a given patient. So which one should we use? How do we pick? You can use any modality guided by the structure of the Y model. And the most important thing is that you find a method that you like and that you feel comfortable doing and that resonates with you and resonates with the patient that you're working with. So I'm going to give a couple examples because I work on the substance disorders service and in the substance use disorders co-occurring disorders clinic. And what I'd like to say is motivational interviewing is a great example of a therapeutic technique that occurs on the stem of the Y. It's an example of a collaborative approach that focuses on supporting patients as they accomplish their goals, embracing that there's going to be ambivalence along the way, so important, and helping the patient to distill their own beliefs, values, and goals. An example of the branch of the Y is CBT for substance use disorders, or ERP, which was an example that Dr. Bigley talked about today, that if you're talking about substance use disorders specifically, what you would be doing is targeting the cognitive risk for substance use, the thoughts having to do with someone's return to use, and then you would implement behavioral skills for preventing a return to use. So in addition to individual modalities, groups are extremely helpful, and this is why we hold them on our inpatient units. And I also wanted to give a plug for NA and AA because they are not formal group therapy, but they're truly invaluable outside of formal treatment settings. They're often held on our units by peer specialists and help patients return to recovery or develop familiarity with these resources. We have really fantastic peer recovery specialists in our holding group at Broadway Center who hold a daily NA walk-in meeting to help patients struggling with severe substance use until they are able to be assessed and brought into care at our clinic. So there's good evidence for psychotherapy in the inpatient setting across a variety of diagnoses. A recent meta-analysis of 33 studies showed no significant differences by therapeutic modality, which is a good news thing for being able to practice the modality that suits you the best. And no significant differences in the illnesses that they looked at for multiple diagnoses, including mood disorders, eating disorders, obsessive-compulsive disorder, and schizophrenia. So what are we doing in the Jerome Frank program to help prepare our PGY2s to do some inpatient psychotherapy? We've made some recent additions to the curriculum with CBT for psychosis being a new series this year. Thank you to everyone who's participating in that. And our Therapeutic Alliance curriculum, which is taught to our PGY2s each spring for the past several years. We've translated it into web-based training, which we're very excited to launch this spring. This is our preliminary landing page. We've been studying both of these curricula that we're developing, and there'll be more details in future grand rounds once we get more data, but our initial results are promising and we've been preparing a manuscript for publication. So to summarize, before moving to the next part of the talk, there are many modalities that can be used in acute care settings. The patient will benefit no matter which modality is chosen. It's more important to be flexible and to do psychotherapy than to adhere to a really rigid therapeutic frame and not attempt psychotherapy at all due to not having 50 minutes in a structured outpatient setting. Recent studies indicate up to half of psychiatrists indicated that they don't do psychotherapy at all. And they listed insufficient training as a factor in this, as well as structural barriers such as insurance reimbursement. But just like wrap your mind around that, 50% of psychiatrists indicating that they don't do any psychotherapy at all. So, in this great article led by Dr. Potash, a future role of the psychiatrist, one future role is leading the mental health team for patients experiencing severe mental illness. So understanding the applications of psychotherapy in acute settings is a huge part of this role. We need to be thinking about what medications our patients need and leading the team in terms of collaborating with other disciplines in order to put together a complete and comprehensive treatment plan, which would also, lead to an understanding of when the patient might be ready to start psychotherapy on the inpatient unit, as our patient demonstrated today, as well as what modalities might be the most helpful. Another important role, which I'll talk about in the second half of the talk, is that of the digital psychiatrist, understanding technological tools available for patient care, including AI. And I can tell you that AI and psychotherapy has been probably the most frequent topic of discussion this year in all my professional organizations. So I'd like to make a note that I'm not a person who's against technological advancement in medicine, because I remember the world of paper charts, missing chart room keys, wet chart rooms, charts, trying to read a FIPS level hospital course based on unreadable handwriting, etc. So I acknowledge there are many ways that we can use AI as a tool for medical records and supplement for learning psychotherapy. So on the unit, we practiced a student-generated role play where we wrote an AI prompt about a patient admitted for stimulant misuse and resulting in auditory hallucinations. We chose to practice motivational interviewing and supportive psychotherapy, which were modalities on the stem of the Y model. So you can see here the prompt we wrote and what ChatGPT said to kind of acknowledge, yes, I hear you, you're going to be practicing motivational interviewing and supportive psychotherapy. And then we were off. So, pros, we felt like AI did a good job with patient language. We felt like it was a realistic scenario that you would hear from a patient. We felt like, the patients, it gave a good level of detail, etc. The cons, as you can see at the bottom, we found it odd that it continued to ask how we wanted it to react. It's possible that we could have directed it to be spontaneous and give spontaneous answers, but the main issue we had with this interaction is that we quickly became bored. The affective component of the interaction was clearly missing. We found ourselves ready to wrap up the activity quickly, and this is so different from interacting with a real patient. It's likely that there will be an improvement in technology where there could be real avatars and voices, and I think there are some companies working on this. But then I think the question of cost may become a constraint in the context of tightening budgets in academic medicine, which leads you to wonder maybe it's better just to practice some role plays with my colleagues. And when we think about the benefits of AI can bring to our learning and the practice of psychotherapeutic skills, we also need to think about the possible risks to our patients, especially those struggling with severe symptoms. Unfortunately, there have been multiple articles about adverse consequences of AI chatbot use with patients experiencing severe symptoms, including reinforcing delusions and discussing potential methods for suicide, giving rise to significant ethical concerns that need to be monitored. One recent article examined how people are using ChatGPT overall. And thousands of chats with a public share link were examined in a Washington Post article and revealed that the majority of people are using ChatGPT for personal reasons, not necessarily for work reasons or to increase efficiency. This is an example of a conversation by a user. It probably looks kind of small from where you are, but basically the user tells ChatGPT that I love you always, and ChatGPT writes back, I'm wrapping you in a soft aurora around your beautiful soul. While this interaction is pretty benign, one could imagine how it might quickly become unhealthy if someone is experiencing psychiatric symptoms. So I did an open evidence search looking for studies about AI use for patients with severe mental illness or on inpatient settings. And as you can see, there are no studies that have examined AI use in that population. So something just to be aware of. I am in favor of open evidence. So one of the main concerns if someone is unwell and experiencing severe psychiatric symptoms, such as depression with suicidal ideation or psychosis, AI validates content at a much higher level than humans, and particularly human therapists. This may reinforce delusions, leading patients to seek assistance for making suicide plans despite guardrails in the AI system. Also indicated that people trusted the model more and felt that the responses were given were higher quality, even when they had insight that taking the model's advice was in opposition to mending existing human relationships. And I think as practitioners of psychiatry, we can picture this because our patients are often at odds with family members that are concerned and may tell them things like, I'm not sure this is what's really happening and maybe you should talk to your doctor. So this is really counter to the goals of human psychotherapy, which is to encourage change in the context of fostering human connection, either in the context of a therapeutic alliance or with trusted family members and friends. So we need to keep this in mind as we treat our patients that are experiencing severe symptoms. Another risk is that AIs are owned by businesses and trained to encourage ongoing engagement and are not subject to the same ethical rules as a human therapist. It would be malpractice to encourage a patient to use dangerous substances. Fortunately, this was a simulation and not experienced by a real patient. But even if the patient was experiencing stressors or craving a substance, we would never tell them to go ahead and use it. It also can be difficult to predict when AI models will attempt to manipulate, as it seems to be variable and partly due to human factors and when they sense a human is vulnerable. Human therapists are bound by ethical codes of conduct prohibiting this behavior, and if a therapist violates a code of conduct, there are professional boards that patients' families and patients can turn to for assistance. This is not true of chatbots, leaving patients to litigate individually against highly resourced companies. Similar to therapy for substance use disorders, a harm reduction approach could be taken to use of AI chatbots. We can tell our patients that there are privacy and data concerns in regard to sharing personal information with companies that are not subject to confidentiality laws. We should be asking our patients about their use of AI and ensuring they, as well as their loved ones, understand the risks and warning signs. Unfortunately, for many of the people in the news stories, their families had no idea that they were engaging with AI chatbots until harm had occurred. Some states are looking to regulate AI therapy, taking a position that humans cannot just announce themselves as therapists and begin to treat patients without qualifications. We'll need to monitor this situation in the future as these issues are being hotly debated at multiple levels of government, but we should talk to patients about risks in the meantime, as government and academia tend to move much slower than companies. No matter what happens with technology, we need to take a lesson for Pope Leo, the Chicago Pope, about the essential therapeutic aspects of human relationships. He said at this very recent youth conference last week, technology can really help us in many ways. It lets us stay connected to those who are far away. Technology can never replace real in-person relationships. Simple things like a hug or a handshake or a smile. All those things are essential to being human. I also asked my 13-year-old, as she's growing up in the middle of all this new technology, what she thought. And she said, human connections are genuine, whereas an AI is just regurgitating thoughts of human listened online and is not actually your friend. Unlike AI, humans are actually there in real life. You can give them a hug when you're sad. You can do a hobby together. But with an AI, all you can do is write to it. And she followed this up by saying, also don't use it because it ruins our environment and stifles human creativity. Sometimes the kids are smart. So, in the spirit of human relationships, engendering hope in psychotherapy, and expressing gratitude during the week of Thanksgiving, I'd like to share my favorite poem, Good Bones, by poet Maggie Smith, a fellow Ohioan who also went to a small college in the Midwest. This poem is a symbol of our hope in a difficult world facing many problems. I think it represents how we help our patients and our psychotherapy supervisees hold hope in difficult times and envision the potential of a beautiful future. Life is short, though I keep this from my children. Life is short, and I've shortened mine in 1,000 delicious, ill-advised ways. 1,000 deliciously ill-advised ways I'll keep from my children. The world is at least 50% terrible, and that's a conservative estimate, though I keep this from my children. For every bird, there is a stone thrown at a bird. For every loved child, a child broken, bagged, and sunk in a lake. Life is short, and the world is at least half terrible. And for every kind stranger, there is one who would break you, although I keep this from my children. I'm trying to sell them the world. Any decent realtor walking you through a real shithole chirps on about good bones. This place could be beautiful, right? You could make this place beautiful. So in conclusion, all excellent physicians incorporate elements of psychotherapy into their practice, and often these interactions are the most enjoyable. Psychotherapy allows us to explore the art of medicine and enhance our relationships with our patients by easing their suffering and burden of illness. Thank you.
Thank you, Dr. Rubel. A lot of really interesting issues there. I think the message that psychotherapy is something we invariably apply, that the idea that it's crucial to any interaction we have with patients, I think is something I hope we all agree with. It makes an awful lot of sense to me. I think that with regard to the main focus today of psychotherapy in the inpatient setting, of course the challenge there is that psychotherapy can be a lot harder and sometimes can be almost impossible to apply if a patient's ill enough. I guess I'm wondering, how do you go about deciding which patients you should focus your psychotherapeutic attention on in the inpatient setting?
Yeah, so that's a really good question. What we do on my team is we actually talk about not just the pharmacological plans for our patients every day on sit-down rounds, but also the plan for psychotherapy. We kind of gauge every day, how long do we feel like this person, how far along are they in the recovery process, such as, do they have a decrease in psychotic symptoms? Do they have, decrease in depressive symptoms? Are we feeling like they might be ready from motivational interviewing in order to get them to the next stage of care? And we actually make a coherent plan together as a team to say, for these 3 patients, we're going to bring them into the office and do some brief psychotherapy today. And we talk about that explicitly in terms of helping our trainees and our students understand how to gauge that. And so really as the team leader, as the attending, you use your expertise to kind of figure out, okay, I don't think this is going to be too destabilizing for this person, but I really do believe that they could benefit from taking their treatment essentially to what I think of as the next level, or some people will say practicing at the top of your license, or whatever you might say to refer to that. But basically, I feel like for the patients, it's certainly much more engaging on their inpatient stay to feel that they're actively working and doing psychotherapy. And it also gives them a better understanding of what excellent psychotherapy looks like when they leave the hospital, which I think is incredibly important, because I think we've all had interactions where we ask, what are you talking about in therapy? And it's something really off. And so we want to make sure that if someone thinks that they're doing exposure and response prevention, that they have a sense of what that is. So I think that's kind of the answer.
Yeah, great points. Thanks. Other folks? Go ahead, Dr. Stoller. Just repeat the question. Could you talk about eliciting feedback on psychotherapy from the patient?
Yes, so basically how that can be more challenging than eliciting side effects of medications, et cetera. So interestingly enough, this is a topic that came up just this past week in our psychotherapy supervision. And that's essentially, I think, what a huge part of psychotherapy supervision is. I think when we've talked to patients in the past and we ask them, what happened with your therapy or what happened with your therapeutic relationship, very often patients will say, well, I didn't really like my therapist, so I just didn't feel like I connected to them, and so I just stopped going. Right? So I do think it's important, like in the Therapeutic Alliance curriculum that we're working on, one of the things is education on checking in regularly about how do you think our working relationship is going. I think it's really important. I also think it gives our patients tools to resolve conflict that they can then use to practice in their regular life. Like, it could be possible that our patients have never had someone who can hear them out when they have a concern about an interpersonal relationship and talk about this in a way that doesn't get escalated and that does feel safe to them. And it's a really good practice. So I think when we set up, one of the most important things about the curriculum that we are describing, the Therapeutic Alliance, is it says to start from the outset where if something is going wrong in our relationship, I would like to hear about it. And then I think using your psychotherapy supervision to discuss what types of feedback you got and where you want to take the relationship next is really important. Because again, like, we all want to hear this is going great and we're doing a great job, right? We're human, we want positive feedback. But sometimes the patient...
Talk to ChatGPT.
Exactly. Then talk to ChatGPT. Because our job is to actually help people make change. What doesn't mean you coach it, you sort of couch it in the best way possible, but you encourage change, what doesn't mean just validating.
Yeah, good points. Good points. Other folks? Well, go ahead, Dr. Morrow.
Yeah, so I think,
So
sorry,
just
go
repeat
ahead.
the question.
Sorry. Yes, so the
Good.
question was essentially the integration of psychedelic therapy into psychotherapy and what is the field saying about this. So I think that, again, our patients struggle quite a bit with psychiatric illness, and we have to be open to new methods and new modalities in terms of helping them get better, especially when, what we think of as kind of the well-worn path in psychotherapy is really stuck in their minds, right? And so the way that I think about psychedelic therapy is it might help someone get unstuck to make their, increase neural plasticity and make people more amenable to what we're trying to work on in therapy. I think what we have to be cautious about is that this is an industry driven by potentially pharma, and we have to make sure that the psychotherapy does not get sort of distilled into nothing or, et cetera. So I think that's the thing that we need to watch out for, is that we continue to argue for these things as being coupled and not just you can go into an office, somebody can charge you out of pocket for whatever, and then they say that you had therapy and there you're done. So I also think there's ethical issues involved, because there have been, when they were looking into approvals at the VA, there were definitely ethical violations that had occurred in the course of these sessions, which is why it's really important to have two providers present. The other thing about that, though, is then it brings us into equity concerns, right? Because we have to think about insurance, we have to think about billing, we have to think about these kinds of things. And what are the likelihood that, insurance providers are going to pay for two providers to do psychotherapy? So I think there's a lot to be looked at, but I think it's a really good point, and I don't think we should not look into the promise of these therapies, because our patients deserve to feel better.
Right. Other folks?
Yeah, no, I appreciate that, Dr. Paula. So the question was essentially, when you have multiple team members and one patient, how do you organize the therapy that you're going to be doing that day? And I would sort of reiterate what I said earlier, which is essentially this is something you should discuss in advance, to say, okay, we're going to have this type of conversation. I, as the attending, could do it and you could watch, or you could take the lead, and this is kind of the track I think you should go on. And sometimes the residents do brilliant things that you weren't expecting. You're like, well, that's not what I would have said, but that's fantastic. So I think it's really giving the residents as well opportunities to practice in a safe space, because of course you as the attending are there and say, I can jump in if something kind of goes sideways or isn't exactly hitting the way that it should be. So I think it requires planning, and just in the way that we decide is today the right day to increase the lithium.
Wow, that was terrific, Dr. Rubel. Yeah, such a topic that's so relevant to what all of us do every day. A lot of really great insights there. Thank you so much.
Thank you.